everyone. I'm Tim Henry, an interventional cardiologist at the Christ Hospital in Cincinnati, and the 2021 to 22 president for SCAI. And I'm so glad that you decided to participate in this dynamic program, and would like to officially welcome you to the Bangladesh Society of Cardiovascular Intervention, or BSCI, annual scientific session on cardiovascular intervention, and the SCAI and BSCI partnership session on CTO interventions. This promises to be an outstanding program and has been developed by wonderful faculty comprised of leading interventionalists from Bangladesh and across the globe on a variety of really timely and contemporary CTO challenging issues, including tips and tricks and case reports that really, I think, will help teach you a lot about contemporary treatment of CTO. The incredible scientific committee has included a variety of debates, challenging and complication cases that will make it, that I think will stimulate discussion on a variety of interventional aspects and make this whole conference more meaningful. So about SCAI, SCAI is the leading medical society for interventional cardiologists that solely represents interventional cardiologists throughout the world and advocates for interventional cardiologists as well as their patients through education, advocacy, research, and quality patient care. SCAI membership is a valuable tool for advancing your career and for keeping you up on the latest guidelines. We are your interventional cardiology home, or really would hope that we can be. And I encourage you to get involved to share your voice and expertise with other leading physicians, not only in Bangladesh, but throughout the world. Thank you, Dr. Rahman and Dr. Azam, for all your hard work and other SCAI ambassadors throughout the world to help elevate SCAI international activities. I hope you have a great time. This promises to be a superb meeting, and I wish I was there with you. So Tim Henry from Cincinnati, have a great meeting.
Thank you, Henry. Now I move our main session. I am requesting our moderator, Dr. Abu Mohammad Shafiq and Dr. Mir Nasaruddin Ahmed and Arun Kalan Sundaram. Please continue the session and hope our wonderful audience will enjoy the big session.
Thank you very much, Dr. Professor Azam. And this is a very wonderful session, could be, inshallah. And very good morning to you all. Welcome to this session. And in this is CTO session, and partnership session is SCAI and BSCI. So it is a very wonderful session indeed. And CTO means it is a very long time and long exposure to radiation, and a very amount of dye is very big. So definitely it is a very big journey, but still it is would be within 1 hour, no doubt. It would be within 1 hour. And we have moderator with us, Dr. Mir Nasaruddin and Dr. Arun Kalan Sundaram. So, and he also will be giving the first lecture. So I would like to request Dr. Mir Nasaruddin to introduce Dr. Arun Kalan Sundaram to for his first lecture.
Thank you very much. Assalamu alaikum. Welcome and very good morning to all distinguished faculties from home and abroad, fellows and attendees. Today is the CTO session already told by the Dr. Shafiq on our moderator. And in our daily clinical practice, especially during coronary angiography, almost 15 to 20% patients will deal with CTUs. So it's a very big number of patients we have to address this proper management. So today we have 4 great faculties, 3 from abroad and 1 from our native, the discussion of Rasulullah. Before going to our final session, I like to introduce our chairperson to take the chairs, and Professor A.K.M. Fazlur Rahman, Professor Mir Jamaluddin sir, and Professor Ashok Sheth, Professor Ramesh Nagawati, Dr. Amar Gutikin, Professor M.A. Ajam, Dr. Shangjo Karla, Professor Badiur Jaman, Professor Kandakar Shahid Hussain, and Professor Muhammad Saidur Rahman Khan. So, and other discussion also here there. Professor Tohidul Haq, Dr. Amrul Islam,
Amirul Khusro.
Amir Islam Khusro, Dr. Mahabur Rahman, Dr. Shamsul Alam, Dr. Kamal Pasha, Dr. Shaila Nasrin, and Dr. Habibur Rahman. So before going to final session, I like to introduce Dr. Arun Sundaram. He's very famous and popular to us, especially in our country. He several times visited our hospital, especially National Heart Fund Hospital, and doing so many cases, peripheral cases, and CTs also. So Dr. Sundaram, his first lecture on CTO PCI, common difficult scenarios and how I troubleshoot. Dr. Arun Kumar Sundaram, please come up and share your slides. Yes.
I hope you guys can see the slides. Good morning, everyone. Thank you so much. It's truly an honor and a privilege to be part of the Bangladesh Intervention 2021. And would like to thank both BSCI and SCAI for having included me in this. So I'm going to try and stick to the time. We're at 10:35, yes. So can you guys see the slides?
Yes, we can.
All right, lovely. So, all right. CTO PCI, as we know, you can run into a lot of problems, and we're going to try and kind of go over some solutions. I'm going to do this in a case-based approach. So obviously, tons of things can go wrong in a CTO, or rather, I should say, we are not talking about complications. Just even doing the CTO per se, you could run into one roadblock or another. You can't penetrate the cap, you've crossed the collateral, can't cross the collateral, microcatheter won't go, you're trying to do ADR, and you just can't do it. So problems abound. So we'll kind of look at a couple of solutions, and then this was pretty much now published. So I would like to kind of show how this would have practical application in a real world situation. So again, typically, just the nuts and bolts. When you have a wire across the cap, but the gear won't follow, and we're talking about anti-grade here. I mean, the first cardinal rule is backup. I mean, if you look at it many times, people go into poor backup, and then you kind of struggle all through during the case. Of course, and then you have the entire, try the lowest profile balloon, different microcatheter. You can do genitoplasty, and for those centers that do have laser, it's something to consider to do it on. Contrast, it's a bit more aggressive, but possible. You could go, if you can't go through the cap, if the device won't go through the cap, you can go around it, can do an external cap crush. All else fails, go to all rota, but of course it does mean losing wire position. And if that doesn't work, switch strategies and go retrograde. Now, again, there are times when you can't even get across the cap, the wire. So again, you can circumvent the point of obstruction using techniques like scratch and go or base. You could try to just create dissections using Carlino. If you do have laser, great. If not, again, go retrograde. You kind of see the common theme. You're trying to increase backup, penetrate, use a little bit more aggressive device, or bypass it. Likewise, if you don't know where to go, the easier thing is to go retrograde or use IVUS and get into that particular area. And same strategies again apply when you go retrograde. You might either want to try knuckle or Carlino. If that fails, go switch direction and go cart, or you could do a retrograde base. And if nothing works, you need to know to stop the case, get a CT, help yourself so that your next attempt is going to be better. Again, there are times when you just can't externalize it and get in. I mean, you might want to switch to a different wire or do tip in. Now, of course, before we had the the RG3s and the R350, the traditional Viper wire, we always used to use the rotoglide. I mean, there are still cases where you might have to do it, although it's increasingly become infrequent. Then the others, many times, having a stent already in place can be a boon. It can also be a bane. So depending on how your instant CTO is, you might want to adjust your strategies accordingly. Again, in the interest of time, I'm not going to go into each of these in depth, but I do want you guys to be aware that this actually the algorithm with an algorithm paper is already published at this point. Now, sometimes when you do have an unexpanded stent, I mean, you have to do something different. Even when you get your wire across, you still want to, change the underlying protoplasm. So you want to, if it is because of under expansion and you're true to true, you want to definitely open it. I mean, now we have open in balloon parts of the world. I mean, of course, you can use IVL, laser when it's available. So you want to create something to get to the tissue outside the underexpanded stent. Now, there are times when you've had to go around it and crush it. Again, basics always start with, especially in the septal, when you have a wire across, but microcatheter won't, is increased guide support, use a guide extension, whatever. You might want to consider dilating the septal if you are for sure, if you do know that it's a complete, the track where you're dilating it is septal. Different microcatheter, sometimes using a shorter microcatheter works. Sometimes, again, we don't use it so much anymore, but you might want to use a wire with a slightly different body. That doesn't work. You might essentially want to give up on the collateral and go to a different collateral, or use a retrograde wire as a marker and come antigrade. Now, with epicardial, the only thing that I'm going to tell you is that you do not dilate it, and you got to be much more respectful. Here again, when you do have, you're in the CTO body and it keeps going to side branch, this is often a problem even with knuckles. You might want to use a wire that forms a bigger knuckle, typically about a 200. I mean, sometimes there are wires that form much bigger knuckles, and that's what you need to do, such as your Gaia or your Confianza Pro 12, etc. And again, remember, the common theme is you're trying more aggressive maneuvers. If that doesn't work, switch strategies. You might want to go retrograde at that point using your antigrade gear as a marker. And if that doesn't work, stop and do, take a CT. So I'm not going to get into the difficult ADR and RER just in the interest of time. And I'm going to try and basically get to the case, because I think we kind of used up the initial 5 minutes with the introductions. So how do you actually apply this? I mean, again, like I said, the algorithm is published. It's out there for people to look at. So in a real world scenario, so here's a patient who had an appropriate indication for a CTO PCI of the LAD, and this was already a second attempt or a third, I don't remember. In fact, when I first looked at the angiogram, I thought, all right, this shouldn't be too challenging. But anyways, be it as may be, those are famous last words. It was the LAD that was the target. Here was, so as you can see, the proximal cap was pretty visible. Distal cap was at a bifurcation, which I would like to preserve, and it was a pretty short CTO segment. So my initial, again, the first thing, once you have analyzed the angiogram, is to have a strategy. You kind of want to know, all right, this is what I'm going to do. There's nothing from the right at all, really, in terms of collaterals, as you can see. So the plan was to do antigrade wire escalation. If that fails, I was probably going to do go retrograde, and if that fails, to probably do an high in ADR and try and preserve the bifurcation. So here is where we started. So again, I'm not a big fan of using single guide, especially when I have the option of going retrograde and it's an IPSI collateral. I try to do it with a ping pong guide because it just makes life a lot easier. So basically, as you guys can see here, I have two guides in the left main. I'm going to kind of go back and forth. You got to be careful about this. That's the collateral. Again, it's not something that you want to take unless you really have to. And the initial plan was to go antigrade. Your LAO caudal view just kind of shows you that there is a lot of calcium. Again, this particular patient did get a CT outside, which we tend to do if it's a redo, etc. But unfortunately, the CT was done at a center where they kind of botched it up, and the patient wasn't willing to get another one, so I had to not really use it much. Now came problem number one. I can't penetrate it. So tried the usual maneuvers, guide extension catheter, etc. Took the stiffest wire that was on the shelf. I really couldn't do it. This was in the pre-laser era, before laser was launched in India. I mean, of course, you could circumvent the thing as discussed and use base or switch retrograde. I kind of decided to go retrograde. So the retrograde option itself wasn't too much of a challenge. Got a wire pretty quick across. Got my microcatheter across. So again, kind of thought, all right, now really close, short segment, should be able to wire this retrograde. I did try retrograde wire escalation briefly, didn't work. So quickly, again, switch strategies. Now, this is where the problem-solving piece comes about. So if something's not working, don't get dogmatic. Yes, it's a short lesion. Yes, I should be able to wire it, but if it didn't work, it didn't work. And so quickly moved on to guide extension reverse cart. And for those that are unfamiliar, essentially what you're trying to do is you're using a guide extension catheter to make reverse cart easier. So it gives a better target, and you don't have to, traverse this long, risky area, which here would include the left main. So by using a guide extension reverse cart. So you balloon antegrade, and then the same space is connected by your retrograde wire. And once this is done, your retrograde microcatheter enters the guide extension catheter, and the rest is easy. Now, next problem, retrograde microcatheter wouldn't move. So, all right, so wasn't the end of the world. So I just did a quick pin, and I'm like, all right, now I got my antegrade microcatheter over the retrograde wire, and I can just bring it forward. And here, again, with the calcium, the Carol wasn't handling great, so it kind of switched to a fine cross retrograde just in the event that there'd be a problem. Couldn't move retrograde, couldn't move antegrade. So now I got a problem. And again, going back to the algorithm, I could try Carlino or Rota, which would mean I would have to lose wire position. And again, a lot of the other options, I'm already thinking about a lot of this. This obviously doesn't hold true at this point. If I pulled it out, put a new low profile wire, there's no way I can get an RX1 into a retrograde externalized wire. So some of these things just didn't apply. So my plan was at this point to go to an external cap crush. So I'll actually show you another picture of that. So what I did do here was we've already gone retrograde. So this is all done, right? So we also found out that in the hospital, the Rota console at that point, again, didn't work. They told me initially that, it's a big center and they had it, but for some reason, there was a technical glitch. So this is external cap crush, where you are kind of going outside that particular area. And this is from another case. But the crux of it is you go subintimal intentionally, leaving the Y there, and take a balloon, dilate it, you're kind of changing the architecture, and then you're able to traverse the whole spot, right? So here, as you can see, what happens is left the retrograde stuff here, got a knuckle going into the subintimal space, and then used a ballooned across the retrograde microcatheter. I thought, okay, maybe this will free up the retrograde microcatheter. Still didn't work, but now I'm already set up for ADR, and I used my retrograde wire as a marker, and I was able to do that without too much of difficulty. So I just got my Stingray balloon down. I think most of us are pretty familiar with ADR at this point, so I won't bore you. Obviously, the view on the right is correct. The view on the left is wrong. I just did a stick and drive. And the rest turned out to be fairly cookie cutter. So once this was done, again, secure your LAD, which is what was done here. And again, use imaging to understand where you are, understand why we're having so much trouble. It's just a lot of calcium. This was post stenting, had to use an opiate balloon, but that was the final result. So in general, CTOs can be challenging. There can be a lot of problems. Know your techniques, have a strategy, and good luck. Thank you. So I guess a couple of minutes for discussion.
Dr. Abu Muhammad, you're on mute.
Yeah, thank you.
Sorry.
Thank you, Dr. Arun, for your outstanding and brilliant presentation, and as well as sharing of your case with us. So any question from our panelists and from attendee fellows as well for the speaker?
From the chairperson first, probably.
So Dr. Arun, just one thing one question from me. How is the experience regarding the complication of you have experienced complication, especially during antegrade procedure or retrograde procedure, and how is the complication rate?
So in fact, one of my favorite talks is avoiding complications. I think, one of the biggest reasons we draw a lot of bad press is just because of complications. I think the key with CTO operators and in general, wherever you are on the learning curve, or even if you're a quote unquote expert, is knowing when to stop. Many times, and even in the algorithm, if you see it, it's like they typically, you're running into problem, solution, and if something isn't working, you got to have to like bail out and then essentially, plan something for a later, for a later date, and that's okay. It's okay to walk away and not have a complication if you can avoid it. I think that's a very, very critical part, as we all go on this journeys to know, when you're dealing with CTOs. So I would typically say the complication rate is, it's about like, 1% or less. Now, that being said, you could have a perf. I mean, perfs are the one thing that always comes to our mind when we're talking about CTOs. So even as you're pursuing each strategy, I think you need to do a continuous risk benefit analysis. Think about, hey, how badly do I want to do it? What are the potential things that could go wrong? And what happens if something does go wrong? Like, is your echo guy around? Do you have a covered stent? Do you have a pericardiocentesis kit? Or, I mean, those things should be going on in the back of your mind as you're doing all of these things. So typically I would say it's less than 1%, but do be prepared for complications because they could occur eventually.
Yeah.
Thank
So,
you. Thank you, Dr. Arun. I am Professor Mir Jamal, Secretary General, Bangladesh Society of Cardiovascular Intervention. For our
Hi, sir.
young colleagues,
Dr. Shafik.
for
Yes,
young
sir.
colleagues, Professor
Dr. Shafik.
Professor A.K. Rahman, I am
Yes, sir.
talking with him. For our young colleague, would you please tell regarding the escalation of the wire for integrate proceeding with integrates for our younger colleagues?
So again, wiring is there are subtleties, and again, a lot of experts on here, and each and everyone I'm sure has their own preference. But in general, the way I approach it is, if I am truly probing for a microchannel, it's something in the XDR or XTA. I mean, obviously the penetration forces are a little bit different, 0.6 versus 1. So it would be one of those two wires. If I'm looking for a little bit more penetration, or if I'm not sure about the course itself, I tend to start off with a hydrophilic polymer jacket at the intermediate wire, such as a Pilot 200, or you could go with a Mongo. If I really want penetration, it's the Conquest Pro 12 or your Conquest Pro. Sometimes I do need a lot of directionality, and if I'm really looking for those kind of things, I start off with a guy a second or a third. But in general, most of your wires should fall in one of these 4 categories. Now we do have newer players in the market, so try to minimize your Me Too products. Get very familiar with wires in these categories, whatever you pick, and then use a lot of those.
Thank you very much. Actually, we are short of time, in fact, because we have spent 20 minutes now.
Hello.
Yeah. Yes, sir.
Dr. Shafik.
Yes, sir.
I want to talk with Dr. Umar. I have a query.
Dr. Arun.
I have a query. If a patient having CTO in left anterior descending artery, but patient remain asymptomatic, one subset, or if a patient having significant, that is not significant lesion in the LED by FFR, then how can we manage such a type of patient? LED is a very main vessel of the heart. So how can we manage it?
In the interest of, I mean, again, you guys are experienced clinical cardiologists. If you do think there's a large area of ischemia and there's going to be a potential prognostic benefit, then I would say yes. I mean,
Yes.
you have 2 options. You want to revascularize either with a minimally invasive bypass surgery, which is not a bad thing if you have a good target, especially if it's a very large area, or you could do a CTO PCI. Now, I'm sure there are people even on this panel that might say, well, the guy is completely asymptomatic now. So why don't we do a really aggressive trial of medical therapy? If there's no ischemia at all, which I'm not sure would be the case, then perhaps you could continue to manage them medically. You could just ping me. We can talk about this offline in the interest of time, if that's all right, sir.
Dr. Arun, another simple question. Just how often did you take the help from the CT angiogram?
So typically, anytime there is another expert has tried, failed, or there's a post bypass patient where I don't know the graft location, for whatever reason, there's really bad anatomic ambiguity, then I do it. I don't do them routinely, although I do think it helps plan it. But again, India, Bangladesh, we need to be cognizant about cost. You need to do it at a good center, otherwise it's a waste of money and effort. So yeah, I mean, I pick and choose the cases where I do CTs.
Okay, thank you very
Thank
much,
you
Dr.
very much.
Shafik. Can we move to
Yeah.
our second speaker, Dr. Shafik?
Yeah,
Dr. Shafik.
definitely. Yes, now Dr. Omar Goktekin is professor and Memorial Hospital from Turkey. It is a SCAI partnership lecture from Dr. Omar Goktekin. He is a very renowned interventional cardiologist and CT specialist of Turkey and in the world as well. So may I request Dr. Omar Goktekin?
Thank you very much. First of all, I'd like to thank Bangladesh Society of Cardiovascular Intervention for inviting me. This very good meeting. Can you hear me?
Yeah.
Yes.
Okay. Yeah. Thank you. Thank you. So I'd like to talk about antegrade approach, and I will talk some tips and tricks in my practice. So when we talk about antegrade techniques, we have basically five approach. The one is single wire technique. Sometimes we can cross the CTO with single wire, or sometimes we need to do step up and step down. Means that we can have sometimes stiffer wire or softer wire or hydrophilic wire. And we do parallel wire technique still. I like this technique a lot, and I suggest this technique to use. This is very classical technique, but not old-fashioned. It's very successful technique in my practice, at least. And we can do IVUS guided entry or re-entry. And lastly, we could use dissection re-entry technique, which basically we could do that by stingray balloon. In Eurosteo CTO Club, there is algorithm for CTO approach. The first of all, for all CTO, we have to do dual injection unless we have nice ipsilateral collateral. Otherwise, we have to do dual injection. Even we have some macro channel, even if we have some antegrade flow, we should do retrograde injection too if we have collaterals, because during the wiring, we might lose that antegrade flow through that macro channel or bridge collateral. So this is very important rule for us. We have to do dual injection during the CTO procedure. So the first we look antegrade cap. If we have tapered tap, we have a more chance for antegrade approach, and we could go to lumen. If we have blunt cap, then we could, of course, we could go to lumen, or we can go subintimal space. And what happened if we are in subintimal space? Then we should look retrograde landing zone, means distal landing zone. If it is big enough, means if it is bigger than trio, then we have great chance, for parallel wire technique. Then we should do parallel wire technique if we have a good landing zone. If we have landing zone less than 3.0, we should look the JCTO score. If it is less than 2.0, again, we can try parallel wire technique. Or if it is high, if it has high JCTO score, which is two or bigger, then we can go retrograde option. Of course, if we failed with parallel wire technique, we can go retrograde option after that. If we fail with retrograde option, in my practice, we go stingray technique if we fail retrogradely. This is our approach in our lab. I like to talk about choosing the wires very briefly. If we have macro channel, or if the CTO is not that old, then we can use loose tissue tracking technique, which we can use Pilot 50, Pilot 200, Fielder XT, A, R, Sion Blake, or other hydrophilic wire. If we like to go intimal plaque, then we have to use some penetrating wire like Gaia, Judo, Ultimate Pro, Miracles, Conquest Pro, or Hornet 14. If you like to go subintimal space, if you like to do star technique or stingray technique, we can do in that time we can use Fielder XT or Pilot 200 to do knuckle wire. So in my talk, I like to focus two things. mostly proximal cap penetration and wiring of the CTO and reaching the true lumen. Let's talk about the penetration of the proximal wire. I'd like to show you one RCA occlusion. First of all, it's very important to see where is the proximal cap. To see it, we have to, use different angle. For example, in here, it looks to me it's ambiguous cap, right, from this LAO view. But if you go from the RAO view, it's not a ambiguous cap for anymore for me, because I know where I should go. If you know where you should go, we can't tell it's ambiguous cap. Mostly, if we say ambiguous cap, means that we don't have any idea where we should go. But here, I know where is the proximal cap, and I know where is the direction. And this is bilateral injection. It's not that long. It's not that long CTO. And in this case, first we try to use Gaia, and Gaia second easily penetrate the proximal cap. Of course, we put a wire from the side to side branch to have stable position. You see the Gaia second, it easily goes in maybe 10 seconds or 15 seconds. So what I do, if the wire goes, I continue to wiring. If it stops, then I'll have some more support on, I push my microcatheter, but if it goes, I let him go. And here, of course, we have to check if we have in the true lumen. It looks very promising to me. And from the other view now, I like to see the distal from the collateral injection. And of course, after I send the wire, I have to check if I am in the true lumen, which is the case. I am in the true lumen. After that, another important rule for the CTO, we have to change this wire. This is stiff wire. This is not a routine wire. We have to change this all CTO wires to workhorse wire. For our workhorse wire is extra support wire for CTO, like BHW or Iron Man or Grand Slam, anyone. But we change it to directly, or Sion extra, blue extra support is also a very nice wire, I should mention. We do 2O ballooning, and this is the final result. So you see that we have some, this will looks like disease, but it's I think that this RCA is underfilled long time. So after 6 months, we will have definitely bigger RCA. So we don't do anything to the distal RCA in this patient. We believe that it will grow. I'd like to show you another example regarding proximal penetration. This is LAD occlusion. You see that we have a very short left main, and my guiding is directly goes to EBU guiding goes to a circ. And from other view, I don't think we can call it ambiguous cap, because I might guess where is the proximal cap, and I can prop it the wire. Yes. So from other view, we have a side branch, it's also disease, but also we have occlusion. It wasn't easy to wire the LAD. Why is that? This is another injection. We have nice collateral from the ipsilateral. So I like to go to, of course, this is circ wire, and I like to go now LAD. It will be not easy because that I just went to circ directly. But what I did here, I just pulled my guiding, and I tried to go from here because the first wire hang me, I couldn't do it. But then I push my guiding. Now it's easy to wire LAD because now my guiding pointed to LAD. Anyway, so what I did here, I did send a FD wire to diagonal. I see that diagonal is not that big, but after that, of course, we have to go CTO. In this patient, I had a fine cross as a microcatheter, and I had Concave Pro 9. Why I choose Concave Pro 9? We can choose here Gaia Cervix as well, or Judo and other stiff wire. But I can use Concast Pro here basically. Why? Because I believe that this is LAD, not that long CTO, and I believe that this is straight CTO. I don't think there is a kink or curve at the CTO body. So my wire went somewhere. You know, this is follows that the vessel means that I am in the intraplaque or subintimal space. Of course, I have to remove my wire and to find the now I'm in that LED proximal cap, and I could penetrate with Concast Pro. My wire position is not bad. When I do collateral, when I do injection, flow is not that good to distal, and I try to go a little gently. This is the same wire, and you know, somehow if you are in the true lumen, your wire will be free. You feel it definitely. If you look like if it does look like that you are in the lumen but your wire is not free, most probably you are in subintimal space. You have to check from the other view, and you will see it. You are in the subintimal space, not the true lumen. Of course, we had to check it, and we did. This is the final result after putting 2 stent in the main artery and 1 stent in the side branch. We did double kissing stent technique here. Diagonal will became bigger, but it's not that big, I would say. Of course, we had to treat proximal cap as well. And I'd like to share with you another proximal penetration. This is LAD occlusion again. If you look here, we have a side branch, you know, a diagonal, and after that we have a CTO. When we have a side branch at the proximal cap, most of the time hydrophilic wire will not work, right? Because our hydrophilic wire will go that side branch. So no need to spend a hydrophilic wire in that case. We should go non-hydrophilic wire if we have proximal cap side branch. You see, this is bilateral injection. We will see better now. The anatomy, very important to evaluate the anatomy if you deal with the CTO, very important. So in here, we choose ultimate miracle trigram. We use this wire sometimes. We used to use it more before, but these days not much. So you please look at it here, right? So miracle trigram always went to side branch, always, because it's also hydrophilic wire. Goes there, I pull back it. You know, I cannot I cannot touch the proximal cap. So no need to try another 5 to 10 minutes because we have very low chance to penetrate. So we should remove, change the wire. And now I had the Concast Pro. Why here I can I have Concast Pro? Because I know that I have to puncture the proximal cap. I have a side branch there. So in here you see the Concast find the proximal cap, and when I push it, it just went to the LAD, not the side branch. It's very penetrable wire. The tip is 009 and the stiffness is 9 grams. So now you see that I will check from the collateral injection. It looks to be not bad, but I feel it's not free. So it means that I am not in the lumen. Right. So I try more with this wire. In here, I see I am not in the lumen, right? I am sure now I am in the lumen. I am not in the lumen, but I know it with the resistance of the wire anyway. So, and then I change my wire guy a second now. This is a kind of step down technique. I have stiffer wire, but it's easy to find the true lumen with the Gaia if you are in the subintimal space, and Gaia easily went to distal lumen. And of course, we have to check. Although I'm 99% I'm in the true lumen, we have to check, of course. And this is the final result after implanting 2 stents in this patient, and we protect the side branch. It's a good diagonal branch, as you see. So we can also step down technique. This is mid Rca occlusion. It's not that long, but it's long occlusion. We did dual injection. We have a curve at the distal. You see that the RCA has a curve. This is important. And in this patient, of course, we did RCA right oblique as well. And I know that this is not this is tapered cap. In this patient, we tried first Gaia third with microcatheter, and please see how Gaia third will behave in this patient.
Hello.
Gaia third now. This is Gaia third because this is tapered wide went easily to CTO, and you know it goes.
No.
As I told you, if it goes, I just you know continue to wiring. From the other view, let's see where am I. In the distal, I'm in somewhere, and the proximal I will be okay. But in the distal, my wire went in either subintima or I think it's a maybe side branch. It looks like to me side branch. I don't think it's out of the vessel. I don't think so, but it could be a side branch. I try a little bit, but since this is a Gaia third, you know, I have a curve there. This is not good wire for the curve, that kind of curve. What I did, I had hydrophilic wire, which is 200 here. 200 pilot 200 is hydrophilic wire. Please look how it behaves. And when I go subintimal space, I have now starting to have hematoma. If I couldn't wire another 5 minutes, I will have big hematoma and I will losing the C that flow, and it will be, you know, and looks like to me CTO goes to more distal. So I had to be very careful not to go subintimal space more. And now I am in. I think I get that curve, very nice. This is nice, but you see that some contrast at that part. It's subintimal hematoma, and I was able to insert my wire to the distal, and then of course we have to check always from the retrograde approach, and this is final result after stenting. The result is a big RCA, and it will be bigger with time. So difficult penetration, what we could do, we could use the double lumen catheter for double lumen for difficult penetration. I have a very good example for that. I'd like to share with you. Double lumen catheter, we have 4 or 5 of them in the market now, and all of them works very well in our practice. So you see, we have LAD occlusion again. After diagonal and septal, we have occlusion. So in here, I had a Corsair as a microcatheter, and my wire is Concast Pro again. Why is that? Because I like to have, you know, clean and sharp penetration in this proximal cap. But you see, my wire either goes diagonal or septal. Sometimes touch the proximal cap. It's easily slip either diagonal or septal. This is, I think, the difficult scenario for us. We have to penetrate the proximal cap. How we do that? We can use double lumen catheter. In here, we had twin pass catheter here, and with the twin pass catheter, we send the twin pass catheter over the septal wire, and then with the other lumen, we send here Concast again, and we were able to penetrate that proximal cap easily, and my wire luckily went to true lumen with this single wire. So double lumen catheter helps us a lot in this scenario. We have 2 lumen in this catheter. One is at the tip. One is monorail. One is the little proximal. That one is the over the wire. So I like parallel wire technique a lot in my practice, and I suggest all, you know, beginner colleague to use parallel wire technique, because it's helped me a lot, and I'm sure it will help them as well. This is LAD occlusion. it looks that it's very bad and ugly LAD CTO, you know, it's, but if you do bilateral injection, you see it's not that that long definitely, but it's a CTO. It looks to be, you know, nice and easy case, right? We have a channel there, shouldn't be that difficult, right? But it's not the scenario. Is, you know, my wire went easily subintimal space, and this is my wire went to subintimal space now, right? So either I can try with this wire, or I can leave it here, which I do routinely if I am in the subintimal space like that. From now, this case is piece of cake for me. Why? Because I know where should I go easily. I mean, you know, definitely. And this is the first wire, and the second wire now. The catheter is macro catheter. I know that my second wire should be 1 or 2 millimeter, maybe 1 millimeter lateral side, right? So I know that now, and my please look at the wire. This is Gaia second. Now in here, I know that I should go this direction. I have to have some space with the first wire. Look how is I am very good position here, and I have to continue. I have a promising looking, and yes, my wire is in the, when you feel that when I am in the lumen, just my wire try to go himself. And this is, we use here double lumen catheter to recross side branch. It wasn't easy. We did this with double lumen catheter, and we did here provisional technique, single stand technique for diagonal. This is the result. And now we have Recross Catheter. This is very good for parallel wire technique. If we need to use double lumen catheter for parallel wire, I use Recross Catheter anymore, because this catheter has advantage to double lumen catheter, because they have two distal hole for the second wire. This is LED CTO, and first wire was in the subintimal space. In that case, I had Recross catheter. This Recross catheter, it has, you know, two over the wire system. One wire just out from the tip, and the other one which will send from the proximal. It either we have two port here, exit port, one either side. You know, material. If this is very good to go from subintimal space to lumen. If, for example, if I out from here, if I am other side, then I change my wire position with going with this the other side port. And with this, we did this case with the recross wire, and this is the final result. So another parallel wire technique I like to show. I'm very fan of the parallel wire technique, and I like to, you know, tell everyone to use it. I don't know, some people hate this parallel wire technique, and I don't know why. It's very helpful. This is also LED CTO. The first, it looks to me that I had a channel here. That's why I had a pilot 200. We could choose also XT here. But unfortunately, I couldn't find that lumen. It goes either septal and diagonal. And here again, I had stiff wire, which is Conquest Pro. My Conquest Pro went somewhere. Conquest Pro always goes somewhere. Remember, it's very sharp wire. If you push it, it will go, definitely. It will go either subintima, sometimes out of the vessel, but it will go. Rarely, if we have a calcium blockage, then maybe it's failed, but always goes somewhere. So in here, at this point, it looks to me okay, but I feel I am not okay in my hand, right? So and you see here, I'm in the subintima at the proximal, which I don't like it. I have a big side branch. I can't lose that side branch. And in that time, please look the other view. Yes, I'm in subintima. So this is the time for parallel wire technique. Now, first, I tried to go this way, try to find a lumen, but I failed. And I tried to go to use the same entrance point. Then I Then after that, I like to change my direction, and I could do it, and I find the lumen. To show you final pose. Yeah, this is the final. I think, guys, I think I have to stop here. I have some more slides, but I think I already take my time. So I have some more slides, but maybe next time and another meeting, I'd like to share with those slides. Thank you very much for your invitation again, and I'm very happy to be here. And I like to be very happy, and I would be very happy to be in Bangladesh after COVID, of course, in physical meeting. Thank you very much.
Okay, can you allow
Thank you,
him
Dr.
to go
Omar
to-
Guptakin. It is a very brilliant lecture, no doubt. And actually, we are very short of time, so we are not going for taking any questions right now. So I just want to move for the third lecture from my friend, Dr. Kaisar Nasrullah Khan. He is a CTO specialist in Bangladesh, and definitely very good CTO specialist I see ever. And Dr. Kaisar Nasrullah Khan, he will be talking on CTO retrograde case, tips and tricks. So let's enjoy Dr. Kaisar's lectures, and then we will discuss later on after Dr. Ramesh Nagawati lectures. So that would be great, inshallah. Thank you. Dr. Kaisar Nasrullah Khan.
Am I audible?
Yeah.
Yes,
Yes. The great Kaisar Khan.
and Dr. Kaisar Nasrullah Khan, the retrograde expert in Bangladesh.
Right,
Dr.
sir.
CTO expert.
And my friend as well.
Yes.
Yeah. So you have to be proud of it,
Definitely.
Dr. Shafiq.
You are also my friends. That's why everyone is my friend.
Yeah.
Assalamu alaikum and very good morning to all. Really honored to be in this CTO session, though I think I am not worthy of it. And my today's topic is CTO retrograde case tips and tricks. I would like to express my humble thanks and gratitude to the BSCI, especially the President Fazlur Rahman, Mir Jamal Chaudhry, who is our Secretary General, and also Ghulam Azam, who is Scientific Secretary, and the moderators, Nesar Bhai and Shafiq, my friends, and Nesar Bhai is senior, and also the SCAI committee for arranging a wonderful conference so that we can learn from each other in this difficult COVID pandemic situation. Hats off to you all. I have nothing to disclose. Well, when to consider retrograde? 1. Proximal cap ambiguity. 2. Poor distal bed. 3. Bifurcation at distal cap. 4. Antigate failure. 5. You have to have very good interventional collateral for retrograde. Now, I would like all of you to focus to this slide. This is the basic of doing CTO. You have to connect the proximal and distal lumen either antegrade or retrogradely only by two methods. 1. True lumen to true lumen wire escalation method. 2. Going to subinterval space and again coming back to true lumen by dissection and re-entry method. This is the basic two method for doing all CTO. No other method is there. So my today's agenda are this. Let's take one by one for doing retrograde. First, using imaging modalities information. So first you have to do the angiogram properly, dual injection, drop magnification, no panning, sequential injection, and long acquisition. So you can see, you can pan, this is a faulty angiogram, and this is the correct angiogram where you don't pan the table and you can see the CTO very good and see the collateral as well. Build up appropriate system. So you have to puncture double. You can be femoral-femoral, femoral-radial, or radio-radial. Guiding catheter should be backup type, especially for left XB, RCA, AL1, or hockey stick, preferably 7 to 8 French, side hole to keep enough coronary flow. And for retrograde case, we have to have short guiding catheter, 90 centimeter. You need wire supporting device. Few of them are this like Corsair channel dilator and support device from Asahi, Teremo fine cross, Caravel Asahi, very short profile of the tip, and you have to you also should have a snare to catch the retrograde wear and get into antegrade guide catheter. Sometimes it could be difficult. IVUS is another important tool for retrograde case sometimes, not always. And the role of IVUS is to know the balloon size in reverse cut and to know the position of the two wears in the space. So you all know there the only four things might happen. Both anterior and retrograde wear could be in the same space, like intimal or subintimal, or one could be intimal, one could be in subintimal. So according to wear position, we can decide to take a bigger balloon, or sometimes if it is in different space, we can redirect one wire into the same space and then connect them with a bigger balloon. So wire selection, shape control, we have different type of wire like Sion family, Gaia, Filter, and Gaia has got Gaia Next, and tapered wire like Pilot, Confluencer Pro 912, hydrophilic and tapered wire. And this is a very important wire for doing retrograde, the long wire, 300 centimeter, 350 centimeter RG3 Viper wire. And wire shaping, but the correct shaping is this. It could have only one bend near the tip for penetration and two tip when you want to guide them, one near bend, one 3 centimeter from the bend. And wire manipulation through the CTO body, drilling, sliding, puncture, push, deflect, torque by Gaia, surfing. You know, sometimes you don't see the collaterals, so you need to surf by Sion Black or Pilot, and knuckling. Now, negotiating collateral channel is very important for retrograde. We've got four types of collateral channels: septal, epicardial, venous graft, lima. And before doing the CTO retrograde, you have to select which one first. And if you fail, then second, then third, then fourth septal or other collateral channels. Ideal collaterals should have more than 90-degree angle, both with donor and recipient vessels, no tortuosity, no bifurcation, clear connections. So collateral estimates, while we are doing RC CTO, LED septal to RPD is 70%, and AV cracks to PLV 50%. You can cross, and sometimes apical LED to RPDA. For doing LED CTO, you can choose PDA septal to LED, or you can choose RB branch to LED or RA branch to LED. And for SARC CTO, you can diagonal to OM or PLB to SARC, or LED septal to LPDA or OM. So while going inside the septum from the anterogate or donor artery, you should give a big bend to get in. And when you negotiate this collateral, you should give a small bend. And if you see visible connection to collateral, Sion is preferred. If it's extremely tortuous, you can take through a wire. And if it's invisible channel, you can try the Filter XTR or FC wire or Pilot. Basics of negotiating collateral: take proper view, take software, be very gentle to negotiate collateral channel, use support catheter always. Wire crossing options: retrograde wire cross. So you hit the CTO from back by retrograde CTO wire after crossing the collateral channel, and cross the CTO body and get the proximal 2 lumen. And then you externalize the wire through the anticate guide catheter. Then you anticate ballooning through the retrograde wire, and then you put the stent. So this is the wire crossing option, true lumen to true lumen. Then the very popular reverse cut, when you can't get into the proximal true lumen by the retrograde wire, you take an anterogate wire, and then you try to dilate the through over the anterogate wire to increase the subintimal space or intimal space, and then redirect the retrograde wire to that large space created by the anterogate balloon and get into proximal true lumen, and then stenting. This is an example of reverse cut. You can see RC dominant CTO with blunt tip and a branch near the CTO. LED, there was a stent, 2 stents which are patent. SARC is non-dominant. So in summary, this is a proximal stump, blunt with a side branch, no calcification, bending less than 45 degrees, CTO 20 millimeter length. Previous attempt was yes. So Jesse's score was 3. So first I tried antegrally with Filter XTA wire, failed, can't penetrate, then take Conquest Pro 9 wire, penetrated but can't get into the distal true lumen, even after several attempts. So decided for retrograde approach, hooked LED, crossed through the septal branch to reach RCA PDA with microcatheter and Sion. So planned for contemporary reverse cut, inflated antegrally 2.5 balloon in distal CTO tried to aim the balloon with retrograde Gaia second wear, but could not connect the antegrade dissection plane created by balloon with retrograde Gaia second wear after several attempts. Then I changed the retrograde wear to Conquest Pro 9 wear, tried to bring it in the same antegrade dissection plane and confirm the 2 wear in the same plane by rotational angiography. After confirming the 2 wears in the same plane, I took a bigger balloon 315 to enlarge the antegrade space and aim it with the retrograde pad. Even then, the retrograde pad failed to pass proximally. I was confident that there should be connection between the 2 planes. Here, you need to sometimes step down. So I exchanged the retrograde pad to slippery filter XDR wear. After some maneuvering, succeeded to pass proximal RCA to antegrade RCA guide catheter. Trap the retrograde pad with antegrade balloon and then took the retrograde microcatheter up in the antegrade RC guide catheter and then took out the filter XDR wear, exchanged it with RG 300 centimeter wear, and then dilated the lesion over the retrograde wear by antegrade balloon and position the stent, deployed, post-dilated. And this is the last picture of the RCA CTO. And sometimes difficult by the retrograde wear to get into the proximal true lumen. And if the antegrade wear is in the true lumen, then we can put a stent there, and it's called reverse cartwheel stenting, very rarely done. So this is another technique. And then after passing the wear, sometimes it's difficult to cross the device. So you have to use low profile balloon, like 1.5, 1 millimeter balloon. You take support by guide extension catheter Godzilla, and balloon technique to get good support. Sometimes if it's difficult, you have to use corners, corsair, and sometimes even rota even. So take home message for all: the 10 commandments for doing retrograde CTO. 1, no ad hoc BSCI. 2, dual injection. 3, study the angiogram. Don't do study the angiogram properly. At least spend your half an hour time to see your plan. Make a plan. Plan A, plan B, plan C. If I fail this, then plan B. Then plan C, fail this, plan C. Check ACT every 30 minutes. If you forget and cause thrombosis, ask your sister to do it. Support. Sometimes you need hemodynamic support if EF is low. ECG pressure monitoring, keep an eye. Sometimes we are so engulfed in doing CTO, there's a bit you don't see. Minimize radiations. Vigilance for complications, predict those things. Perforation, have cover scan into lab. And persistence. So take home message: retrograde approach has the potential to be the last reliable method to recognize CTO. Battle against CTO can't be won on the day of procedure, rather day before the procedure. So planning for imaging, strategy, and technique, appropriate hardware and device is very important. Contemporary reverse cut is new technique to increase the chance of success in retrograde approach by specific aiming the antegrade balloon with Gaia wear and preventing enlargement of retrograde dissection plane by retrograde wear. There is no shame in referring difficult and or failed cases to expert operators or cabbage. Sometimes it's better to lose your ego to win patient's heart. I'm indebted to my cath lab team and my colleagues in the United to help me doing the CTOs. Also, I express my humble gratitude to my Japanese colleague, especially Satoru Suzu, who came to Bangladesh and taught many of us the retrograde cases. Thank you, Sensei. Keyword for success of CTO. You're a long line to P. And of course, as an intervention cardiologist, you're the last person in the queue. So to reach your goal, you need to have patience. And you're climbing a mountain. To reach to the top of the mountain, you need to have perseverance. So my point is that patience and perseverance are the keywords for success of city. So you need to try, and try. Thank you all.
Thank you very much, Kassan Nasrullah Khan. Our last and final speaker, Dr. Ramesh Nagawati from USA. His talk on CTO complication, how should we tackle the complications?
Thank you very much, Chairperson. It's a great pleasure on behalf of SCAI to partner with the BSCI for the CTO complication session. So without, as we are running out of time, I'll be very quick and try to get this program going. And we have a mission statement from SCAI for mostly education, and I would encourage everyone to become a member. Complications of CTO also, as I think Dr. Nasrullah Khan very well mentioned, that sometimes it becomes a battle between the physician and the artery, and we might actually start causing more damage to the proximal coronary artery, vessel perforation, aortic root dissection, or damage to the collaterals. This is from Sudhir Rathore, and where from his experience at Toyahashi Center, he showed that the typical rate of death, bypass surgery or MI, is about 3 to 5%. Tamponade is the most common perforation, but I mean, it's the most drastic perforation. But the septal perforation appears to be the more common, about 3.8%, and side branch compromise can happen in about 5.1%. I think specific complications can happen either to retrograde approach and channel rupture, or potentially overwhelming ischemia from the donor artery, thrombosis of the donor artery, and prolonged ischemia that can cause a dominant collateral channel damage due to instrumentation. Somebody, I mean, Dr. Kamal Pansha asked a question about anticoagulation. Definitely keep it around 300. And obviously all the CTO patients will have a prolonged DAPT if there is no high bleeding risk. So septal channel rupture, usually small and contained by myocardium, causing a small asymptomatic hematoma. Most of the times we can leave this alone. Otherwise it keeps enlarging, then it actually needs the treatment. This is from Dr. Sabha, and you can look at some similar algorithms from Sanjog Kalra and Robert Riley and others as well. And even Sanjog has done from open CTO registry that the retrograde CTOs are associated with more complications than antegrade. And so whether you go for parallel wire technique as well as antegrade dissection reentry are more preferable, and you need to be really very careful whenever you go for retrograde. But if there is a good channel, you should attempt the retrograde. I'm not saying that you should not. So common complications, when you look at the bottom of this, is cardiac tamponade, thrombosis, side branch occlusions, dissection, embolization, including air, and because sometimes we deep seat the guides, and spasms also can occur in these people. So I think I mentioned about open CTO registry and progress CTO. The more higher JCTO score, the higher complication rates that can happen in these patients, because we are spending more time in opening up these arteries. So let's look at quickly some cases. A 75-year-old with a typical angina and anterior wall ischemia, and he was referred for a CTO. As you can see, the LADs are completely occluded. A wire is placed in the diagonal, and a retrograde attempt from RCA. And as we went through all these slides earlier, Dr. Nasrullah Khan as well as Dr. Arun and now Omer have shown great cases. And I'll quickly only go and show. So this is a case that has been completed, stented the LAD. You should actually pay attention that there's something here outside the stent and near the carina of the LAD and diagonal. But we did not pay attention, so it was stented, and we're very happy that we got a beautiful result. And looking at later on, patient developed a cardiac tamponade and became hypotensive, and we recognized it. We tapped the pericardial effusion, and you can see that there is blood flowing out of the LAD now. What happened? So where is the perforation? So we put a covered stent in the LAD, but still patient is hypotensive and the blood is draining. So then put another covered stent in the diagonal, because sometimes at the carina, it is always difficult to know where that is coming from. You can see very clearly that it is probably from the junction of LAD and the diagonal. And so we took another covered stent for the diagonal, and after that, actually, patient did not have any further hypotension, and we did final kissing balloon inflations, and there is a flow through the diagonal and as well as into the LAD. So sometimes you might have to sacrifice the side branch with these type of perforations, and then open up the side branch with maybe 14-gram wire. So that's sometimes you have to do that. So that's the final picture on that. Here's a septal perforation. As I said, that the majority of them can be stopped. You can see that there is a septal perforation clinically inconsequential, no hypotension. There's probably no therapy is required. That to most of the times. Okay. And whether this patient has a retrograde approach to the right coronary artery injection with the corset, and you can actually see that nice successful reverse cart, and subsequent angiogram showed that there is a small perforation of the PLV. And so we kept waiting, maybe thinking that right now it's completed, whether we can, it'll heal on its own, and waited for 5 minutes and 10 minutes. It is still getting slightly bigger. And after 20 minutes, there is no point anymore, and it's getting much larger. So that's not going to close. We sacrificed that with the appropriate coils. And after 2 coils, there was no completely sealed off a perforation here. So 2 coils were given to that small branch in the PDA. So another septal perforation, you can, which we had to be treated compared to the first one. Here, this patient Rca CTO wire was not crossing, and multiple attempts were made, deep seating the guide, and ultimately, actually, there was aortic dissection, and with repeated puffs, the dissection kept increasing, and immediately the cure is trying to stent the proximal RCA to aortic junction. And so if you look at aortic dissections, you can classify them to 1, 2, 3, and 3 is the one that is we are always worried about, that is the cusp to aortic arch more than 4 centimeters, and most of the causes are guiding catheter trauma and repeated injections through that, and sometimes balloon rupture also can cause that antegrade dissection. In my last case, it was actually a NC balloon after doing a beautiful left main by DK crush stenting. My fellows went up to 18 atmospheres on the left main balloon inflation. Proximal optimization technique of, sorry, not 18, more than 22, and that resulted in aortic dissection, and I had to put a short stent again to cover that. Coronary artery dissections can happen. You consider minimize the contrast injection, consider mother-child catheters, and stent intracoronary entry point dissection with a conventional stent or a covered stent. The last one actually I did with a conventional stent, and that itself was luckily we were able to close it. So TEE, and somebody also asked the use of CT, coronary angiogram prior to doing CTO is now recommended in complex CTO cases. I think in view of time, dissection is probably all of us are very good with it. And this is another case where there is a perforation and tamponade not immediately recognized. Use softer wires once you cross the main CTO. In this case, that was not done, and hence the Conquest Pro caused a dissection, a perforation. And the people kept ballooning at the site of perforation, which actually really worsened it much worse. And the patient actually collapsed completely. So you need to balloon tamponade proximal to the perforation. And even if it is a little bit proximal, it is all right, So the treatment is obviously people who are older and female gender and having calcifications and high balloons to stent to artery ratio. These are the people who will have perforations. In addition to using any of these extra wires, hydrophilic coated wires, atheroablative devices, etc. And so perforations for LS3, obviously you have to be worried about what needs to be done. Immediately covered stent, if you can get hold of it. Please make sure before you start doing CTOs, you need to have, or any complex PCI, you need to have covered stent in your cath lab. Brelakis has talked about nicely in this paper of his and in the textbook. Treat the main cause, covered stent, prolonged balloon inflations, while you're waiting for the covered stent to come from a different hospital that I had to do in China one time, and embolization with the fat coil or thrombin, and if it is a distal vessel perforation, and also maybe sometimes you might have to sacrifice that vessel by putting a covered stent across that artery. And so this is another mid-LAD CTO successfully performed. You can see there is a balloon in the RCA, and everything was done well. On the LAD was being concentrated. As you can see, people are concentrating on the LAD. And at the final injection of the right, here there is a thrombus in the distal right. And so obviously you need to not only pay attention to the main vessel that you treated, but also the donor vessel that you went through. And so many devices go through this donor vessel, it can cause a thrombus. So just a gentle thrombectomy is enough for most of these patients, and making sure the ACT is around 250 to 300 towards the end, and if need be, you can give a little bit more heparin. So I think in view of time, I'll go to most important points. You need to worry about the radiation, antegrade versus retrograde. As I mentioned, more complications can happen with retrograde. Prepare detailed PCI strategies based on the high quality angiogram without panning, as mentioned by Dr. Khan. Measure ACT and keep it within your target range. For us, it is about 300. And everything should be seen on the same screen at all times, and use guiding catheters more than 7 French without a stiff and tapered tip. Do your best to identify the entry point into CTO, and IVUS or any OCT should be done when an antegrade wire passes through an occlusion into the distal side branch. And use a spring coil wires as your first choice of collateral channel tracking when vessel course is not clear at all. And the knuckle wiring is the safest when vessel course is not clear at all. And Omer prefers parallel wire, that also could be done. Osteal LAD CTO has the highest risk of serious complications. And so this, I would not say that the beginners should start with an osteal LAD CTO. And a stent delivery into the left circumflex should be guaranteed, just in case if you are going with the LAD CTOs. So take home message: detect perforation early. Don't ignore subtle findings, as I showed you in a couple of cases. Inflate a balloon to stop bleeding, and perform pericardiocentesis if unstable. Treat the cause: large vessel perforations, covered stent; distal vessel perforation, fat or coil embolization. Number 4 is most important: remain calm. Communicate with the team. Everyone in your team should know what is happening. So in the take-home message, people who are at a higher risk of complications, also low ejection fraction, less than 35, active heart failure, elevated EDP or wedge pressures more than 35 millimeters of mercury, large area of severe ischemia, jeopardy score being high. Even in the best of best hands, complications can happen. In these type of patients, have a balloon pump or an impel or ECMO also available, because we sometimes think we ignore that ejection fraction or hemodynamic collapse can happen, and people might need these support devices. With that, I'll stop here. Thank you very much.
Thank you, Dr. Ramesh. That is very brilliant lecture, because we used to learn from the complications mainly. So this is a very good lecture indeed. So I want to take some comments from our chairperson, Dr. Sanjay Karla there. Dr.
Yes,
Sanjay Karla,
yeah, I'm here.
please give some comments.
No, I really enjoyed all of those lectures, especially the case-based examples that we used throughout. I think the goal with good CTO PCI programs is start slow, be careful, and start programmatically. So if you're going to bring CTOs forward, make sure that the communication with the team is particularly strong so that they understand why you're doing the procedure and the planned procedure that you're going to perform, so that everybody understands not only what you're trying to achieve, but what can potentially go wrong. And so that you're prepared for it. One of the things that Dr. Nagawati just brought up was how important it was to communicate with the team. And having done a 6-hour case today that I knew was going to be a 6-hour case, it was critical that the team knew exactly what we were doing, why we were putting the patient on a tandem heart support pump, and why we were going to have to use a bifurcation technique in the midst of an epicardial retrograde to be able to recanalize this. Otherwise, the room would have ran away and said, this is nuts. There's been a lot of questions about whether or not we should do CTOs in asymptomatic patients, and I think there's been some really nice discussion on the chat. As Dr. Kalyana Sundaram has pointed out, and as Dr. Nagawati and others have pointed out, the importance is doing what's right by your patient, right? So if you've got an asymptomatic patient, it's hard to sell doing anything to them unless you can actually put them on the treadmill and prove that they are symptomatic, prove that there's clear ischemia. The one thing that I will mention, this is my personal opinion, the data bear this out to a degree, but not in a randomized trial format, is that in individuals who have LV dysfunction with retained viability, attributable to a CTO territory, you have an independent indication to revascularize, right? But once again, that discussion has to come with an important informed consent around why you're doing what you're doing, and the honest sort of risks and benefits and complications, potential complications associated thereof with your patient. But really well done. That was a great session.
So Dr. Ashok sir, are you here, sir? Ashok sir here?
Is not with us.
No, he's not here yet.
No,
He's not
he's even messes right now. So I knocked him. That would be great if Ashok sir is here. But now, Jamal sir.
Yes, thank you. It's a very interesting and learning session. We are grateful to the SCAI authority because they have made this program in collaboration with Bangladesh Society of Cardiovascular Intervention. As the secretary of Bangladesh Society of Cardiovascular Intervention, I have the gratitude to you, and I am congratulating you to arrange this program. And regarding this program, we have learned much more regarding the CTO management, both integrate as well as retrograde. For the younger colleague, I have to say, whenever you want to do a CTO, your team must be prepared before your team. Your cath lab setup should be prepared, as because you will have to have all the materials what is essential regarding the different types of wires, balloons, and last not the least, a covered stand. With this backup support in your cath lab, then your team, then enthusiastic team should be there, and then expertise is also important, and all together will have the goal to success in this CTO. So CTO program is a different program, and this program needs specific expertise as well as all these materials, which is essential. Thank you all the foreign speakers as well as my country speaker, Dr. Kaisan Nasrullah Khan. And thank you, SCAI authority, for collaborating with us. Hope that you will remain with us in our heart, in the heart of Bangladesh Society of Cardiovascular Intervention, as well as with Bangladesh. Thank you once again.
Thank you all. May I request Dr. Rahman to conclude the session, sir?